Good afternoon, everyone. On behalf of the organizing partners, the WHO Collaborating Center, European Public Health Association, the Global Network for Health in All Policies, and Finnish Institute for Health and Welfare, I would like to warmly welcome you to today's webinar. This session is designed to bring forward diverse perspectives on intersectoral collaboration and health in all policies approach. We hope um, we hope to highlight how these strategies contribute to stronger, more equitable public health systems. Also, this session is part of a broader series of webinars connected to the European Public Health Conference, which will take place this November in Helsinki, Finland. We have a short video introducing European Public Health Conference. It's 50 seconds long. My colleague will now share her screen and start the video. Thank you. I hope you enjoyed this short video. We will put the video link on chat box as well. And please note that there will be additional webinars following the summer break. So we encourage you to stay informed by following our organizers' social media accounts as details become available. Now, without further ado, I will give the floor to Lauri Kokkinen, Senior Researcher at Tampere University and co-director of our WHO Collaborating Center. Lauri, the floor is yours.
Thank you, Kokkan. So I'm Lauri Kokkinen. I work as a co-director of the WHO Collaborating Center here at Tampere University in Finland. And just to have a shared understanding of health in all policies, let me start from the social determinants of health side. So from that side, we know that human health is mostly determined by the context in which we find ourselves and by the life that we are able to live in that very context. And if we would roughly believe, for example, these estimates from the Canadian Medical Association, some 10% of our health would be determined by biology, 1/4 or so would be determined by healthcare, and the rest would be determined by the context where we happen to be born and by the decisions that we are able to make in that context. So in other words, our health is very strongly affected by policies beyond the healthcare policy. For example, the housing policy, educational policy, financial policy, environmental policy, and so on. And then to keep it short, health in all policies is an approach to systematically consider the health impacts of policies beyond the healthcare policy. But today our question is, why is health then not taken into account in all policies? So I will start answering by looking at the competing policy objectives within governments. And my colleague Meri Koivusalo will then continue by looking at the external pressures from outside of governments. So I would argue that major policy decisions are always or usually made within these government systems. And these systems decide whether the health impacts of policies are evaluated or not. And if the health impacts are evaluated, these systems decide how much do the health impacts weigh in policy decisions. And this specific framework was developed by our Harmonics project team. This systems framework includes 3 subsystems. Subsystem means the 12 different ministries that we have and who all have their own very own objectives. And the objectives of each ministry are directly visible in their names. There is one ministry dedicated for health, and then 11 other ministries dedicated, for example, for finance, employment, education, environment, agriculture, and so on. And all of these ministries have different amount of power and resources. And usually these ministries are or sectors are very well aware of the hierarchy between the different ministries. In Finland, for example, the Ministry of Health often frames their health issues as employment or economic issues, as it knows that it's easier to kind of gain wider policy support this way. And the Ministry of Environment then frames environmental issues in health terms because it knows that the Ministry of Health is more powerful compared to it. And for intersectoral issues such as health in all policies, the governments then have some kind of or different kinds of cross-sectoral structures and institutions. So first, if you want to implement HiAP, you of course need to have some kind of mandate to interfere with the domain of any of these sectors. And for HiAP strategy, it's very important to have some kind of political mandate to evaluate and to consider the health impacts of policies beyond the healthcare policy. In Finland, for example, there is a legal base regarding the, for example, the health impact assessment, which is one of the main tools for doing HiAP. And of course, this intersectoral action also requires management that brings together the different sectors and often also some kind of specific expertise. For example, for the impact assessments and for example, enhancing the policy dialogue. And the third part of our systems framework is the executive subsystem. And the executive subsystem includes the political elite, meaning, for example, in the Finnish case, the parliament. And it's important to note that the political elite always has some kind of specific ideological lens through which they look at different policy alternatives and different policy problems and possible policy solutions. For example, they have a specific ideological lens on what should be the role of the state and the role of the market and the role of the individual in promoting and protecting population health. And the government also usually has a specific agenda and this agenda can only fit a limited number of problems and limited number of solutions during one government term. So, for example, in Finland, the government nowadays writes a very detailed program for 4 years at a time, and this government program is then kind of a Bible that the government follows for 4 years. So, all in all, what I tried to introduce are the main governance institutions that decide whether the health impacts of policies are evaluated, and if the health impacts are evaluated, whether they are really taken into account in policy decisions and in real politics. And we of course need to remember that there are always also other important impacts, such as the environmental impacts. and economic impacts. And sometimes these different impacts are in direct conflict with each other. And then it takes politics, for example, ideologies and power relations to decide what impacts matter the most in policymaking. And at other times there are win-win situations, or even this kind of win-win-win situations between the different impacts and between the different policy sectors and objectives. And finally, I kind of claim that the governments are important for HiAP implementation, as major policy decisions are made within these government systems. But at the same time, it's of course crucial to understand how external pressures from outside of governments affect the HiAP implementation. And my colleague Meri Koivusalo will now next talk more about this topic. Thank you.
And for our audience members, Meri is a professor at Tampere University and co-director at the WHO Collaborating Center at Tampere University.
Good afternoon. I work with Lauri in the WHO Collaborating Center, and I'm not going to be talking about the external factors, because not just government policies and structures matter, but they're also influenced by external actors. And one of the kind of thematic areas for the EUPHA conference are commercial determinants of health and corporate political involvement. And I would just kind of talk a little bit about those. And if we take Lauri's triangle on executive policies, and then intersectoral ministerial kind of influences, and then intersectoral focus, we can highlight that we have got a lot of kind of initiatives on the innovative promises and solutions, which quite often in the side of the healthcare and health are something that fit into the medical or individual treatment, and thus support the kind of intersectoral focus, and rather than intersectoral. I mean, we have had a lot of debate lately on the obesity medicines and what is their relevance. We know that lobbying to change policy priorities, norms and regulatory practices is something that has become kind of a more prominent within the societies. Some people call it as growth of the market power within decision making. But this is kind of something that affects especially the executive. The politicians tend to hear a lot from the kind of a business interests, and they have got the right, of course, to inform the policymakers of their kind of needs and interests. And then we've got a third dimension, which is kind of the struggles and kind of a scope for intersectoral action. And there we have very often in many of the tools and means for intersectoral action and health in all policies, we emphasize participation and stakeholder presence. But that also kind of implies that all stakeholders are present. So you have also kind of a scope for influence by the kind of corporate stakeholders. We've got early engagement and public-private partnerships often presented as kind of a means for intersectoral action. So we would like to have see that our kind of health in all policies are driven by strategic priorities. Yes. So the strategic scope for HiAP is always kind of defined in terms of strategic priorities by health problems that we want to solve, by something that policies that we would like to kind of take further to see the change, and then kind of political support for these to take place. And that has been the kind of in the prior WHO conference on the health promotion, the kind of idea of what kind of affects the health in all policies implementation in practice. But I think that it is essential for us also to kind of recognize that the three streams and the opportunities can work for health in all policies and implementations of intersectoral action, but also against it sometimes, or kind of undermining the scope for it. And I think that it's important to see that both directions are possible. And I think thirdly, I would like to raise the kind of different strategies and toolboxes and what we have gathered some knowledge, and WHO Europe has also published a big report on the commercial determinants of health. But essentially to kind of raise the importance of kind of sharing the experiences across public health professionals, across public health actors, because I think that very often we are kind of faced, especially with alcohol and tobacco policies, we are kind of faced with multinational industries, which seek often to kind of restrict the policy space through focus at European or international negotiation. Sometimes the policy priorities can be sought to be changed through kind of a changing of the national policy priorities, pushing for more emphasis on innovation and sectoral kind of policies or interventions and competitiveness, or changing norms, practices, and accountabilities in terms of health impacts and assessment of health implications. So corporate political involvement may not be kind of a directly oriented towards their own interest, but it can be oriented towards the whole policy environment that takes place, which kind of would then serve also their interest. And this is particularly the case with tobacco industry, which has not been able to be part of the policymaking community in the same way as other industries have in practice. I think we have also kind of differential implications in terms of media and advertising. And it is important to remember that these shape both demand for products, but also kind of the politics of what is kind of missing, where are the kind of needs. And we also see their influence that if we engage the stakeholders and industries very early in the decision making, there is kind of a much more time to kind of derail or kind of think about different options or propose the alternatives. And very often there's a great imbalance in terms of financing of resources between the non-governmental organizations, which can be kind of sometimes built on voluntary activities, public health associations, and then transnational industries, which have got capacity to have oversight and participate at different levels of governance. And finally, we've got also kind of challenges of how the focus of policy action and priorities are set. Increasingly, we can see the individual focus on problems and solutions, rather than kind of a wider structural emphasis. And we've got an increasingly higher threshold for regulatory action and policy measures, including policy kind of aims and practices from better regulations to the anticipated implications of regulatory chill from potential challenges or implications should the kind of impacts of the kind of regulatory action be against big stakeholders, such as has been the case with the environmental regulations very often, and environmental and health regulation in particular. And then we've got also power and capacity difference between the public health sector and the engagement of intermediary public relations agencies and influences in favor of promoting policy choices which might be against public health. And I think that there is a lot to learn across countries and across kind of scientists and policy practitioners in how to address the corporate political involvement, how to gain and learn from each other to manage it better. And this is not only important in terms of in all policies, but I think that the current kind of just published third report on social determinant of health has highlighted the role of social determinants and structure of determinants for health and conditions of daily life that we face, as well as the kind of a new megatrends, which are climate change and digitalization, which will and can influence the health policy practice in ways which we may have not anticipated before. So we need more intersectoral action, and maybe we need more multisectoral action. So this is over to the next speaker. Thank you.
Thank you so much, Mary, for this insightful presentation. We appreciate your insights following Laura's presentation. And next, we have Marianne Jacques, Scientific Lead for the National Collaborating Center for Healthy Public Policy. She's joining today in her role as Coordinator for the Global Network for Health and All Policies. And Marianne, the floor is yours.
Thank you, Gökhan, and thank you for Larry and Mary for setting the stage for this this webinar. And thank you really for the Tampere team for organizing the webinar. So I'm Marianne, and today I'll be speaking about how health and all policies, or HiAP, approaches can help governments respond to complex interconnected challenges, and how the global network for health and all policies is supporting this work. So as Larry and Mary touched on, health is health, but more specifically health promotion, often takes a back seat in public decision making due to competing objectives within government, power dynamic, lobbying, silo structured, and so on. And these challenges play out within a broader context, as governments everywhere, and Mary touched upon it, are facing overlapping and interconnected crises. So climate change, inequalities, economic pressures, and health threats. And these complex challenges, often described as polycrisis, can't be solved by any single sector. Yet most public institutions weren't built to respond to this kind of complexity. Siloed structures, while useful for specific mandates, often limit coordination, shared accountability, and sometimes even innovation. And so addressing today's challenges call for policy approaches that are collaborative, equity focused, so that we don't leave anybody behind, and aligned across sectors. And by combining the strengths and mostly the levers of different sectors, governments can better address the social determinants of health, help equity, reduce duplication, use resources more effectively, and develop innovative solutions. And this is where health and all policies come into play. Just to go back, and Larry really rapidly shared what health and all policies is, and it really is a governance approach that integrates health into decision-making across sectors by really addressing the broader social determinants of health. Larry initiated his presentation by demonstrating really what does impact an individual's health. And it's really about the social determinants of health and other sectors having the levers to impact people's health. And so HiAP promotes collaboration, strong governance, and long-term partnerships that are aligned with the Sustainable Development Goals. And HiAP provides not only the rationale, but also practical insight that governments need to collaborate more effectively across sectors and ultimately build more equitable, resilient, and sustainable societies. But, and contrary to what the name might suggest, HiAP isn't about health imperialism. It's not about putting the health sector in charge of everyone else's agenda. It's really about working across sectors to identify shared goals and create policy co-benefits so that health, equity, and sustainability are advanced together across government. And it's more than a concept. HiAP provides a practical pathways to better policy outcomes. And to help governments implement this approach, WHO developed the HiAP 4-pillar model, which provides a roadmap for putting multi-sectoral collaboration in practice. The 4 pillars are here. We have governance and accountabilities, leadership leadership at all levels, ways of working together, and resources. And these are all themes that Laurie and Mary talked about in different models that are used to talk about how we can address health and health equity. And so together, these pillars provide a practical foundation to support collaboration and ensure that policies across government contribute to a healthier, equitable society. And the model serves both as a diagnostic tool, but also as a planning tool for governance seeking to build or to strengthen ongoing multi-sectoral collaboration. So now let me turn to how the Global Network for Health and Health Policy supports countries in putting in this into practice. So the Global Network is a country-led initiative launched in 2017 by the government of Sudan, Finland, Thailand, South Australia, and the province of Quebec in Canada. And we're working to support countries and stakeholders in working across sectors through knowledge sharing, capacity building, and practical tools. And it's really about providing a global platform to connect countries and build capacity. And we support that work by offering members opportunities to showcase their experience in implementing health and health policies, recognizing that HiAP takes many forms depending on where it's implementing, the local priorities, governance structures, and policy entry points. And so we also offer webinars, workshops, and other resources to support practical action. And I just want to touch on one initiative that is emerging from the Next Network's recent work, which is the second edition of the Global Status Report on Health in All Policies. This report will be informed by data collected through the 2025 Global HiAP Survey, which builds on the first global survey that was conducted in 2018. And so the 2025 edition is now structured around the 4 pillars that I mentioned early on, and allows for a more systematic assessment of how countries are operationalizing HiAP to advance health and health equity. And so building on the survey data, the report will document where and how HiAP is being implemented, what's working, and what enables that progress, and what are the challenges that remain. And this resource will act as a knowledge product in itself, mapping global practice on health and health policies and strengthening that evidence base. But it can also be used as an advocacy tool to support strategic decision making and sustained momentum for multi-sectoral action. This work is led in partnership with the Global Network, Australia's Centre for Health and Health Policies Research Translation, South Australia's WHO Collaborating Centre on HiAP implementation, and Tampere University WHO Collaborating Centre on HiAP and the social determinants of health. And so we see with all these partners, and there are so many others, a strong interest in supporting capacity in this area. And so we're quite excited to see how this second edition will deepen our understanding of HiAP in practice and hopefully help shape future tools, indicators, and strategies to really strengthen practice. So as I wrap up, I just want to offer, if you want to stay connected with the Global Network's work, I invite you to visit our website, join our mailing list for updates, resources, and upcoming opportunities. The links are on the slides there, but I'll drop them in the chat once my presentation is over. And also, if you are already involved in health and health policies, we would really want to hear from you. And so we're really encouraging you to complete the Global Status Survey on HiAP, which remains open until July 4th. I'll also drop that in the chat. So thank you again for being here today on this Friday afternoon, morning, depending on where you're at. And I'm looking forward to the conversation. Over to you, Gökhan.
Thank you, Marianne, for the excellent presentation, especially given the early hour in your time zone across the pond. Now we have, last but not least, Charlotte Merchandise to deliver her presentation. Charlotte is the Executive Director for European Public Health Association and European Public Health Conference. Charlotte, the floor is yours, and please feel free to share your screen.
Thank you very much. Very happy to be here and to share this so important topic, and also hoping to share it with as many people as we can, because we need to share not only what is HiAP, but also the method, tools, and examples that are working. But I'll try to answer the question of the webinar: why is health not yet taken into account in all policy? And I take that from my position at EUPHA and the exchange I have, but also of my former commitment as a politician. And we have strong evidence. We have amazing example, and Finnish have been leading the way around. But some things are probably not helping us. One of the things is the academic debates, and they are really interesting. And you mentioned it, Marianne, health in all policy is not imperialism. And then sometimes we go and say, can we do health for all policy? Of course, we have the structural silo, but there are also lots of concepts that seems to be competing when it comes to policy, like economy of well-being, One Health, planetary health, urban health. And when you work to politicians, of course, environmental health, I didn't put it here. Sometimes they just see a bit of it and they will do their policy based, oh, I want to put everything on One Health. But the method, the way you do it, the way you get people together, the way you actually measure the impact is the core of the 4 pillars of health in all policy. So it's not because the entry point will be on one subject or the other, or resilience, because it's a big theme in Europe right now. Health in all policy is a way to go. So it's sometimes we need to be clearer that health in all policy is not competing with all of these concepts. I think it's actually supporting all of them and supporting people to actually do it. We know sometimes it's too rhetorical, and I'm French, and for a long time it's been really incantatory. So we had some health in all policy ministry committees, but it was once a year and it was, talking about it. I can see also sometimes that people are talking about health in all policy, but they're not putting any money on it. Doesn't work, right? We need HiAP. Marianne, you've been talking about the polycrisis. Polycrisis requires transformation. And I've seen we have people from our member Ukrainian Public Health Association, and I can tell you that we have a lot to learn from what they've been doing through the huge crises of the wars they've been going through and how much they learned. And we should all learn, because most of us, we are lucky enough not to be at war, but we are in a very bad situation. It's time. We need transformation. We need to do things differently. And the good thing is that we have a roadmap. I'm saying not yet implemented. Cities are leading the way. The work of the WHO Healthy City Network in Europe and the national network and what I can see in local government is amazing. They're actually doing it. But sometimes local governments are too far away from the global network. So you've been doing a lot of work with the global network on that. And sometimes the very, very good example on how we tackle the economical, social, commercial determinants of health actually don't come from national government. They come from regional or local government. So we should, even in research where we stand at EUPHA, try to put more researchers and support better the local actor who are actually doing it in a very politically committed way. So what we want to do at EUPHA is really contribute in Europe to empower the public health workforce by equipping professionals to engage with all these sectors. And it's not the same vocabulary. You don't speak with finance and education. And I think there's a very good question in the chat. We can go back to that later, but you don't speak with the same vocabulary. You need new tools. You've said that. You need negotiation tools. You need political tools that maybe you don't have as a public health professional. And we need to be a lived competence, not a concept. And we need to exchange again on best practices. And in EUPHA, we're working toward credentialing. We're also publishing in next November a supplement of the journal where Mary, amongst others, is contributing, that we will give example of implementation in very diverse ways. So sometimes if you are working in the health workforce, yes, you can do health in all policy. If you're doing urban health, if you're working on a health system and green transformation. So trying really to show implementation and have scientific article on that. We are really looking forward to presenting this issue of the journal. And then join us in Helsinki. So EPH conference has received 3,000 abstracts and almost 300 workshop proposals. So we are on very high numbers. Registration is open. Secure your place if you want to join. And we really look forward to seeing you in November in Helsinki, with or without the sauna, but at least with good science, good evidence, and good networking. Thank you very much. Last but not least, stand up for science. Ideology is very bad for health. In EU, all our association are losing money because of the ideology of the Commissioner of Health in the EU Commission. This is really bad. We need to stand up, not only in the US, we've been talking a lot about it, but also in Europe. Thank you.
Thank you, Charlotte. Thank you so much. We've heard 4 insightful presentations so far, and I already have several pressing questions. So in this next portion of the webinar, we will address questions submitted by the audience during the session. I encourage our audience to use Q&A function to ask questions. As our time is limited, I'll go straight into the questions. I think this first question is a more general question that's not directed to anyone in particular, so please feel free to take a stab at it. So the question is as follows. To what extent do current HiAP models embrace the concept of reciprocity between systems? For example, if schools' education ministries are to commit to truly promoting health in comprehensive school health approaches, will health ministries be funded and be mandated to provide school nurses in schools? Does anyone would like to, I think Charlotte mentioned this in her presentation, but.
Well, I think it's a very interesting question in the fact that there's not one answer. And from my experience, we're really DIY every time. And negotiation means depending of who you're talking with, and sometimes you change minister, you change the win-win thing. So yes, we need to see how they're committed, but the money doesn't go in your pocket. I mean, if you improve health through changing the environment, the money saved for health will be saved for health, not for the environment minister. So you need to find another action. But I think our Finnish colleague will be the best to answer that. I know example at local government levels and how you can find other benefits for them.
Thank you, Charlotte. Would Mary or Lari like to answer that from a Finnish perspective?
Well, I can answer from the, I don't know if it is from a Finnish perspective, but maybe in terms of the aim, I think we have to accept that the different governments and at different levels of government, people can organize things differently. So it might not be at the core of the HiAP model, but for example, in Finland, you have had kind of people who have been kind of nurses or kind of a school health, then to kind of be provided by the health sector. But of course, the challenge then sometimes is that if you have got a service provided by another sector, then if another sector kind of becomes squeezed by funding, which is all over the kind of countries that the ministries of health and social affairs are squeezed with funding, then the temptation to cut something that is not at the core activities or where you're responsible becomes higher. So that's why it is always kind of that's another challenge with the intersectoral action, that you would like to have it as a joint activity to kind of keep it going and to have a budgetary recognition it as within the kind of both sectors, because otherwise there is a risk that it becomes cut first as something that's not on your own budget line. And performance-based budgeting tends sometimes to make it much worse. And it is a kind of common problem that a lot of kind of HiAP practitioners are discussing. So thank you for the question.
Thank
Maybe
you so much,
Gökhan,
Mary.
if I can, I can jump in. My connection is better, so
Yeah, go ahead, please.
sorry if I drop off. My connection is a bit weak, and I think it depends on the HiAP implementation models, right? There are so many different models, and it's in some cases it can be about health providing funding or central government providing funding across sectors to support action on the social determinants of health. If I'm thinking about the Quebec experience, with the government prevention policy they implemented, there was funding through different sectors at different level of government to support action on the social determinants. So it might have been resources to have municipal actors conducting health impact assessment, for instance. So in that context, funding did come through the health and all policy approaches. In other cases, it's not about the health sector providing the funding, but it can be about what can health bring to the table. Can health support bringing evidence to support making the case in different types of settings. So I think it depends on the model, and it depends also on how can we work together to advance our own agenda, and what can I bring and what can you bring, and how can we make an impact together. So yeah.
Thank you. Thank you, Marianne. We appreciate it, and we hear you quite great. No issues there. So the next question asks whether the following quote is still relevant for health policies. Here's the quote. Why treat people and send them back to the conditions that made them sick? Anyone would like to answer that?
Yes, it's still relevant. Very relevant.
And if I can add on that, totally agree with Laurie. What is different, I would say, is that it's becoming increasingly complex. And when it's complex, we tend to lose people because we don't take the time to explain everything. We speak in very complicating jargon, and the stakes are huge. We are also facing huge disinformation and misinformation, both of them, active disinformation. And we are facing so many things. I mean, if you see the determinants of obesity, they are so numerous. I mean, even being exposing to air pollution during your fetal time can be someone that leads to obesity. So we, as humans, we want simple solutions, and we are facing huge complexity. So we are putting people back in what put them sick in the first place. But we just had a study in France releasing that we have huge levels of cadmium. And even if we would go back to normal numbers of pesticides, we are not following the EU rules. And, you know, we knew some things, cadmium is new. We would not cure the people within 10, 20 years. What can you do with that? You know, you feel helpless. And this is where you need coordinated answer, because the complexity of this world makes it not that easy to say, okay, if you're an environment with pollution, you cure people with no pollution. It's worse and worse, and we need to have lots of time with communities and have communities champion if we want to succeed.
Thank you, Charlotte. Excellent answer. I would like to ask if anyone would like to take on that question, or we have a couple of more questions in the line. I can jump to them. I think that's the right thing to do. So the question is, how do the speakers consider HiAP? Is it a method or tool? Different research groups are applying HiAP differently, and so we are struggling with standard performance indicators as well as reporting structure.
Maybe I can start, Gökhan. I think as I mentioned, health technology policies is an approach. There are multiple tools within this approach that can be used to implement it, right? And so I think it depends. Monitoring is a challenge, is a challenge for demonstrating impact of these types of approaches. And it's both a challenge on different level. How do you make the case for such approaches when you don't have the data to support and back it? So that's a real challenge, a real struggle. There are multiple frameworks that can be used with different indicators. And this is a bit where we want to be heading with the global status report to kind of look into those indicators. But the implementation contexts are so diverse and the objectives also are so diverse that one size fits all and one model, one approach won't work. So I think it's looking across the different resources and mobilizing what makes the most sense in your setting. And, you know, are we having impacts in terms of how we work together as a government across ministries? Are we consolidating relations, structures to work better together? So those are types of impacts. But then are we having an impact on the health of population? And this brings back to the difficulty of demonstrating impact of prevention in health. So I'm not providing a strong answer to the question, but a few pieces to reflect on, I think, and maybe others want to contribute.
Thank you, Mary. And I think Mary would like to answer.
Yeah, I think that we shouldn't think about it as a tool approach in the same way in all countries, but as a strategy, as a kind of a set of thinking and as a kind of a model and different options to kind of achieve action on the kind of particular health problems that you have and which you need to kind of address. And I think that we sometimes think that, you know, if you kind of reach certain indicators, then HiAP is done. I don't think HiAP is ever done. I think that needs to be kind of accepted. It is an approach to kind of seek how to kind of relate to the intersectoral health issues and multisectoral health problems, which are the most complex and difficult to achieve. So I did the kind of the opposite, or kind of the not the nice thing, and said that it's the question is wrong, which one should never do. But this time I think that one could argue that it is important to say that it's not a tool and it's not a method. It's a strategy and approach.
May I add something?
Sorry, go ahead. Yes.
Yes, well, I agree with Marianne and Mary. So I also see HiAP as an approach. And I also see it as a kind of state of mind or a way of thinking about the policy process. And oftentimes when I talk with our Ministry of Health and Social Affairs, I tend to say that that's HiAP is what they should keep in mind when they go to other ministries. Because it's the objective of the Ministry of Health, but they should also keep in mind that it's a resource. Health is a huge resource for basically all other objectives in society. So they should kind of keep HiAP. That should be the state of way of thinking for the Ministry of Health people, in my mind. So yeah, it's a bit confusing, but I see health as an outcome, but also as a resource, and HiAP as a kind of a state of mind.
Thank you, Lauri. We had really excellent insights to this question. I appreciate it. I'd like to move on to the next question. Why is HiAP not conceived much as an intersectoral approach? What are the limitations in this case, especially in the European public health application of HiAP? Would anyone like to answer the question? If you need some time to ponder about it and come back to it later, that also works for me. Okay, Larry, I think you'd like to go.
I think it's a good question, but could you repeat it?
Why is HiAP not conceived much as an intersectoral approach? What are the limitations in this case, especially in the European public health application of HiAP? So why is HiAP not considered an intersectoral approach or conceived an intersectoral approach? Perhaps the audience member who asked the question can clarify what you meant by that?
Yeah, I'm not sure if I agree with the assumptions behind the question. So,
Okay.
Is it so that it's not agreed as an intersectoral approach?
What do others think?
I think HiAP is intersectoral. I mean, lots of intersectoral action goes through here, but it's not intersectoral in the sense that it is within the public sector. It's not between public and private sector, if that was what it was meant. And I think that there is a reason, or many reasons, why that is the case, because in terms of the policy making, in terms of the decisions that are made, then that often takes place within the public sector. So I think HiAP is intersectoral in the sense of the public sector, or multisectoral in relation to the more complex problems and challenges that one might need to kind of address.
And maybe Gökhan, building on Mary's comment, I'm not sure, I don't know if it's a vocabulary question or a conceptual question, difficult to answer in the chat, but I think in essence, it's how we work together really across government, and depending on the implementation model, it is also with government, but also if I'm thinking about the Thailand experience in implementing health and all policies, which has a strong focus on the non-government sector, so that, you know, it is also intersectoral in that manner. So across sectors within governments, but also how do you work with sectors outside government, depending on the approach that you mobilize for implementing it. So I think it's pretty much, it's really much about intersectoral, cross-sectoral, multi-sectoral, depending on the language or the vocabulary you mobilize.
Thank you, Marianne. And this is the beauty of live Q&A, because everyone can interpret the question differently, and it gives a better room for great answers. So thank you both for answering, or all three of you. So the next question is, how do you see communities considered in the HiAP? If there's lack of space for including community planning, then is not HiAP promoting another top-down bureaucratic exercise? Very difficult one, but I'm sure someone would like to. Yes, Charlotte, go ahead.
Oh, I would love to. I love this question. It's so interesting. So first of all, when we talk about public health, we talk about equity and participation. When we talk about health in all policy, it's not only engaging sectors and governance and intersector, it's also co-creation, collaborative. And the framework emphasizes equity and accountability. And if you emphasize equity, you emphasize accountability, especially including those most affected by the policy. So it's on the roots. And sometimes we need to say our values again, because we go to new concept and we forget why we do that. So yes, it can be bureaucratic. It's what I described that happened some years ago in France. It was really ministerial level. It was awareness raising. It was not health in all policy. But there are ways, and we've seen them, and I've saw lots of examples I've seen through the global network. You can elaborate, but participation is like my topic, my favorite thing in the world. But I think if we want to avoid that, we need to embed community participation explicitly, especially from policy design. And there you have tools. I mean, we have the method of HiAP, then you have tools, and we have good tools like participatory budgeting, citizen jury, health impact assessment. And health impact assessment, if you want to do it well, we have all these. We just had a EUPHA midterm conference on health impact assessment. You need community input. We need to recognize a community-based knowledge, and that's where you've got indicators, because you have indicators from community and you're empowering them. And in time of polycrisis, it's win-win. And so how do you connect to grassroots organization? So that gets again to the previous question. And how do you, and this is a hard one, institutionalize accountability mechanism? Because if you have accountability mechanism, community can monitor progress and influence. Last point, tell the policymaker it's win-win, because I've been doing that a lot in healthy urban planning. In healthy urban planning, health is a good thing because you get so much many people than if you just do a community, consultation just on the road. Health is a priority for citizens. Health is a priority for voters, and it can get lots of people in your policy. So it's a core value for public health people. But it's also something that brings lots of light and lots of new people to other policies. So in public health, we have methods to engage communities that are absolutely very interesting for other sectors.
Thank you so much, Charlotte. And this is actually a follow-up question to what you said, because we were wondering what other practical steps that European institutions could take to move from rhetoric to implementation. Do you have a take on that, or would anyone like to answer that? What practical
For
steps?
me, it's training. For me, we need to train more in different ways, and lots of people, and create cohorts, people that can actually talk to each other. So that's why we are also partnering with you, doing the journal and seeing what people do from that. Cohorts are a good way to go, because then they do a signal group and they exchange. And I know I've been training for a long time, and they still ask me to come and train. Last week, 2 weeks ago, I was in the south of France training 101 cities that want to include health in their strategic planning for 2025 years. And it's the whole strategic planning of the 100 cities. And they actually, they still ask me to do it. So I went there. It's not my job, but I went there because I was trying to really see how we can scale it up from there and take responsibility at European level and give some kind of credit, and that we create link with other countries, because I would love to go and visit other countries. And I think the more, in other, if we have political roundtable in the EPH conference, like having politicians saying, oh, I did a lot of good things there. And we need to, it's what you said about commercial determinant of health. We need to tell the story. We need to advertise. Coca-Cola spends so much more money on advertisement than the whole money of WHO. Advertisement work. We need to create the story. And to create the story, we have people who are able to tell the story. So that's my take at EUPHA. And last thing, we cannot do it alone. So that's why being in partnership with all of you is amazing, because we can find champions.
Thank you, Charlotte. We would love to collaborate with you as well. We are right on time, but does anyone have a question or comment? Very shortly. If not, I think it's time to finalize our webinar.
May I just thank you, Charlotte, for those. It's kind of nice to see that kind of enthusiasm and positive attitude, because we are in the academic circle, we are so good in finding problems and very bad at suggesting any solutions.
Thank you, Larry. So before we close, then I'd like to thank our speakers for their valuable contributions, our partners for their support, and all of you for joining us today. A recording of this session will be made available on the European Public Health Conference website, so feel free to revisit or share it. I invite all of you to register for the European Public Health Conference in Helsinki in November. It will be an important opportunity to build on discussions like today's and strengthen our collective efforts in public health. And thank you all for joining us today, and I wish you all a nice day.
Thank you, Gökhan. Thank you, everyone. Take care.
Thank you. Bye-bye.
Thank you. Bye.